Okay, thank you for introducing me, Dora. So to bring the presentations to a close, I'm hopefully going to bring together little pieces of all the information that you've been given this morning, and also emphasise the importance of communication between the blood bank and the obstetric teams. I've got 3 cases for you this morning or this afternoon. So our first case study is patient V, who booked with us at 9 weeks and had a positive antibody screen. Our laboratory performed a panel in-house and then sent the sample to the National Blood Service for confirmation. As an aside, this lady's first baby was born with thrombocytopenia, but this resolved spontaneously. Neonatal alloimmune thrombocytopenia was queried, but this was never confirmed. The report from the National Blood Service on the sample that we sent confirmed that the patient had an anti-LUB or Lutherin B with a titer of 4. Now, you might well ask yourselves, what on earth is one of those? And you wouldn't be alone, because some of our doctors didn't really understand what it was either. But if we go back to Kath's talk, that is one of the clinically significant antibodies. So what's the problem? So anti-Lutherin B is a very rare antibody. It doesn't prove to be much of a problem for the baby. So the risk of hemolytic disease of the fetus and newborn was quite mild because Lutherin antigens are only very weakly expressed on cord cells. So it was unlikely to cause any problems as far as the baby was concerned. However, as far as the mum was concerned, it was a completely different case. Lutherin B is what we call a high frequency antigen, which means it appears on the vast majority of the population's red cells. In this case, it's approximately 99.8%, which means should the mother require blood during delivery, only 0.2% of units that the National Blood Bank hold would actually lack that antigen and be able to be transfused to the mother. So taking into account mum's blood group, B positive, and the K negative requirements for all women of childbearing age, only 0.1%, so 1 in 1,000 of all the red cells that the National Blood Service hold would potentially be compatible. So hence my very small diagram there with the 1 green splodge in amongst the 999 red splodges. So I hope you can see this. This is the report that we received back from the National Blood Service. And as far as the obstetric team were concerned, it just stated what it would state in the case of most of the other antibodies, that a repeat sample at 28 weeks and a cord sample at delivery to test for a DAT. What was not taken into consideration was the part that read blood selection. Now, because the number of units, it says that we will need a lot of notice should the mother require blood, because blood may need to come from the frozen blood bank. It's kind of that rare. So, you know, it could be a problem sourcing blood. And if we did get blood from the frozen blood bank, it would probably take 2 to 3 days to actually reach us. So we would need a great deal of notice before mum was due to deliver. So what did we do? So The mother was added to our antenatal spreadsheet, which we have for all mothers who have antibodies, and it gives information regarding when the next specimen is due, what the current level of the antibody is. So at 21 weeks, she came to book at the hospital antenatal clinic, and it was documented in her notes about the anti-Lutherin B antibodies and what the guidelines were. The patient was referred to fetal medicine. She had an antibody, even though it was a low risk one as far as the baby was concerned, but more to monitor her baby for possible NATE. All the attention was focused towards the fact that could this baby potentially have NATE. So by 34 weeks, the titer had reduced to 2. So again, the anti-LUB was not considered to be a problem. And again, the possibility of NATE was still being monitored. The laboratory continued to send out the spreadsheet on a weekly basis, but no escalation had occurred at this time regarding the availability, or rather unavailability, of blood, as the delivery date was still 6 weeks away. And as you can see, that is just about to come back and bite us. So unknown to the laboratory, a decision had been made to deliver the baby at 37 weeks due to the possible NATE risk. So a request arrived on a bank holiday Monday. Of course it was. I happened to be on shift in the laboratory on that day, so remember it. So they requested 2 units of red cells to be cross-matched for an elective caesarean the following morning, as they would per protocol for all patients with antibodies. Now, for most other antibodies, that wouldn't necessarily cause us too much of a problem. We are a large hospital, we hold quite a large stock of blood, and we are fortunate enough to have a national blood service actually on site. However, as the availability of blood of this particular antibody is so rare, that wouldn't necessarily be the case. So what happened next? Well, amidst the panic, there were some frantic phone calls and emails to try and clarify that this was a serious request from the team involved. Phone calls were made to the National Blood Service in order to determine the availability of required units, to which we discovered there were 4 in the entire country, none of them local. So more frantic phone calls to try and notify the obstetric team that there was currently no blood available, so the operation would need to be postponed. But bearing in mind this was a bank holiday Monday, it was a bit tricky trying to get hold of the relevant team, because the last thing we wanted was for this lady to be wheeled off to theatres with no blood cover at all. Eventually, the haematology SPR did manage to get through to the obstetrics team and advised that the operation should not proceed until a discussion had been had with the blood bank that blood was actually going to be available for the procedure. So on the following day, the consultant anaesthetist was aware, and the decision was taken to postpone the caesarean for the consultant led list on the day after. So what was the outcome? So 2 units were transported from the National Blood Service directly to our laboratory. They were cross-matched and sent down to the delivery unit, ready for the procedure. The other 2 units were held at the National Blood Service in Cambridge, which could be transferred over if necessary. The outcome was that a baby boy was safely delivered. The estimated blood loss was 500 mils, so actually no blood was required. The baby was healthy, no evidence of NATE. no evidence of hemolytic disease of the fetus and newborn. But things, clearly communication, particularly, dare I say it, from the laboratory side, was not what it should have been on that occasion. The obstetric team should have been made more aware of the fact that blood was not going to be readily available to them. Since this incident and the third one that I will share with you, communications have improved. We now have a weekly meeting to discuss ladies with antibodies or other complications, and we liaise with the obstetric team to hopefully prevent scenarios like this from ever happening again. So our case number 2 is where things actually has been since our introduction of our meeting, where things did go a little more smoothly, shall we say. So this patient booked with us in her 4th pregnancy. Blood group is O positive. Her first pregnancy was a stillbirth. Unfortunately, no cause was ever established. Her second pregnancy 5 years earlier was uncomplicated. However, by her third pregnancy, she had developed an anti-little c. And as you know from Kath's talk earlier, this is one of the big 3, if you like, the ones that are most likely to cause severe hemolytic disease of the fetus and newborn. So this lady was monitored according to protocol. Her partner was tested and found to be homozygous for the little c antigen, meaning that all children from this partnership would be little c positive. The antibody levels were monitored and the baby was delivered at 36 plus 4 weeks and had phototherapy and discharged home at 10 days. So by the time she came to us for her 4th pregnancy, we knew what to expect and things were put in place. She booked with us at 13 weeks and already her level was at 5.3, but that still leaves her in the low risk category. Again, the fetal genotyping unsurprisingly confirmed that the baby was little c positive. By 24 weeks, the level had risen, and again, by 32 weeks, she had gone into the medium risk category. She was also being monitored for fetal anemia by using the MCA Doppler, and this showed a peak systolic velocity of 1.86 multiples of median, indicating that there was a high risk that the baby was anemic, even though the titer was still in the medium risk category. So they decided to deliver the baby the following day. However, anti-little c not only causes potential problems for the baby, it also again causes potential problems for supplying mum, well, not supplying mum with cross-matched blood, but should things go dangerously wrong, mum cannot have the emergency O-neg blood that we do keep down in delivery unit, and neither can baby, because baby would have the same antibodies in its system that mum had. So why is this? So the reason is that our O negative emergency blood is usually always little c positive, so cannot be given unless it's a life-threatening emergency to ladies that have anti-little c. So what did we do about that? So the laboratory cross-matched 4 units and sent them over to the delivery unit prior to induction of labour. An alert was put on the lady's system that the emergency OD negative units were not to be used unless it was a catastrophic bleed. Then on induction of labour, a further 4 units of red cells were cross-matched and sent over to the delivery unit. In our hospital, we can monitor when blood is being taken out of the fridges. So the laboratory were under strict instructions to monitor when blood was being taken out so that they could cross-match and supply blood in a timely manner should it be required. The National Blood Service were also alerted to hold a suitable unit for the baby in case an exchange transfusion was required. So the outcome was that a baby boy was delivered by caesarean section. The hemoglobin was within the normal range. Bilirubin slightly raised, so the baby had to have some phototherapy treatment, but all was fine. The baby was discharged home on day 17, and fortunately, no blood was required by mother and baby, but we were prepared for this one. So thankfully, it wasn't necessary, but it's always good that we were prepared and the correct communications took place. So on to my last case, patient K. So this case looks like everything went, well, I wouldn't go as far as to say smoothly, but the outcome was positive, but there were errors and learning things to be learnt along the way on both sides for this. So this was her 3rd pregnancy. She'd had 2 previous uncomplicated pregnancies, 12 years and 9 years earlier, with no history of antibodies. She was not actually one of our patients, but she was referred to us from her local hospital as the booking sample had showed an anti-D level of 1.7, which shows it's an immune anti-D. It was documented in her handover notes that anti-D had been administered at delivery on both previous pregnancies, and there hadn't been any transfusions, miscarriages, or terminations since. At 16 weeks, the level had risen to a medium risk, so she was referred to the fetal medicine unit. Unsurprisingly, fetal genotyping predicted the baby to be D positive. So the level continued to rise. By 28 weeks, the level was 25.9, which puts her in the high risk category, but her MCA Dopplers were still fine. By 30 weeks, although the level hadn't risen much between those 2 samples, the Doppler showed a PSV at greater than 1.5 multiples of medium. So mum was referred to King's College Hospital for an intrauterine transfusion. 10 days later, the PSV had once again risen to above the level for treatment, so a further intrauterine transfusion was carried out. 8 days after that, again, the level had risen, so plans were made to deliver the baby 2 days later at 34 weeks. Fortunately, and it will come to light of why I say fortunately, that we had some blood available for an exchanged transfusion ready for the baby at birth. So the baby girl was delivered with a low hemoglobin and a very high bilirubin, which put her above the treatment threshold for an exchange transfusion. Cord bloods were taken for grouping. Mum was given anti-D and a sample was taken for FMH. The baby required 2 double exchange transfusions and triple and double phototherapy, which finished at the end of day 3. So on day 4, she was transferred to a local hospital, received 2 further top-up transfusions, and at her 16-week checkup appeared to be fine. So on the surface, everything seems to have gone well, but there were near misses, errors, and lessons learned along the way. And I can see from the chat that already one of those lessons has been noted. So, first question was, how did the mother come to have immune anti-D when she received prophylaxis after her previous deliveries? Well, the simple answer to that is we really don't know. There are some possibilities. Did she have a large silent FMH towards the end of her previous pregnancy, which wasn't picked up? Did she have a large FMH at delivery and insufficient anti-D was administered? We don't know the answer to that because she delivered at a different hospital. Was there an undocumented termination or miscarriage? Did she have a raised BMI? Because sometimes in women with large BMIs, the anti-D does not work as efficiently as it could do. The answer to that is not that we're aware of, because when she came to us, her BMI was in the normal range. Or when she did have anti-D, was it given within the correct time frame? Again, we can't really answer that question. But it is a rare occurrence that even if all the guidelines were followed and all the anti-D was administered within the correct time frame and the correct amount of anti-D was issued, it is still possible for a mum to become sensitized. And we think this is possibly what happened in this case. So the second point was, again, communication. Now, our blood transfusion laboratory system is completely separate from the system used in the rest of the trust, meaning that at that time, sometimes important information was not readily available. At delivery, the blood transfusion laboratory were unaware that baby K had had 2 intrauterine transfusions. So the reason they need to be aware of that is because if a baby has had an intrauterine transfusion, they will require irradiated blood up until 6 months post their estimated delivery date. Blood for exchange transfusion is always irradiated unless they can't wait that long for their blood to be irradiated, but generally it is irradiated, and the unit that we had cross-matched for the baby was irradiated. But if the baby had been born and only required a top-up transfusion, at that point the baby would have received non-irradiated blood. So unsurprisingly, the laboratory were also very confused because when the cord sample was taken at delivery, it grouped as O negative. So they had to ask themselves, why was this baby O negative when clearly due to mum's anti-D levels, it was positive. The anti-D level had risen throughout the pregnancy. Baby was anemic. Had the samples been mislabeled? The answer was no. We tested the blood sample and it was from the cord. There was no way the fetal genotyping could have been incorrect. So the notes of the mum were interrogated at this point, and the evidence of the intrauterine transfusion was discovered. So that would explain the findings, because the laboratory were actually grouping the transfused blood and not the baby's own blood. So the blood group should and was altered to be recorded as unknown. So as I said earlier, communications since then have improved. And finally, As many of you may have spotted, why was the mother given anti-D and had an FMH sample taken? Both were unnecessary as the mum was already sensitised, so this consequently had to be reported to SHOT. And the laboratory had to realise that actually at that particular point in time, their method of reporting anti-D did not differentiate between immune and passive anti-D. Everybody was reported as anti-D. So the midwife team were quite used to seeing anti-D on a lady's reports and still injecting anti-D. At that time, the laboratory were not responsible for issuing the anti-D. Pharmacy were responsible for supplying the anti-D. So as a result of this, the laboratory now have 3 different types of anti-D reports. We have anti-D immune, so anti-D prophylaxis is not required. We have anti-D passive and anti-D unknown. In both cases, anti-D is continued to be given because it should always be given if there is any doubt about the origin of the anti-D. So I hope that you've learned something from some of our case studies. Thank you for listening and for staying here. Has anybody got any questions?